I'm Rachel Rebouche. I'm the interim dean and professor of law at Temple University Beasley School of Law. Our chapter describes the proliferation of telehealth for medication abortion. Medication abortion is the two-drug regimen, mifepristone and misoprostol, that can be taken before 10 weeks of pregnancy. Recently, the FDA changed the regulation of mifepristone, the first drug in the regimen, to allow certified providers, to mail medication abortion directly to patients. We expect that within a year's time, certified pharmacies will also be able to dispense medication abortion. Our chapter maps how virtual clinics delivering counseling, screening, and services online have grown since the FDA's rule change.
Hi, everyone. I'm Greer Donley. I'm an assistant professor at Pitt Law. So Rachel described the confluence of factors that led to the rise of teleabortion over the last few years. I'm going to quickly explain what this all looks like in a post-Roe world. So without the protections of Roe, half the country is expected to ban abortion. Some abortion seekers in these states will travel for abortion care, but many will not be able to afford it. However, unlike the pre-Roe era, medication abortion opens up the door for these folks to have access to safe abortion in their state. An international organization known as Aid Access has been providing medication abortions to eligible patients via telehealth, even when it is not permitted by state law, and people can buy the medication directly from international pharmacies. Though states will view this conduct as illegal, it is not clear whether they will practically be able to stop it. So our punchline is simply that right as the anti-abortion movement is about to realize its decades-long goal of overturning Roe, the nature of abortion care has shifted and decentralized, making it almost impossible to control. We're quick to note in this chapter that though medication abortion is a game changer post-Roe, it will not solve everything because it is only approved through 10 weeks of pregnancy. There are disparities in accessing telehealth, and most importantly, there are legal risks. But despite these barriers, medication abortion will help many people in anti-abortion states safely into pregnancy. Now I am going to answer the first question, which is, what is one thing you'd like people to know about this area? I'm going to actually kind of repeat something that my co-author Rachel has argued in previous work of hers, which is that, the future, the next decade of abortion access and law will see kind of a delinking of these two main things. In other words, even though abortion might be banned in many states, we're still going to see people having access to abortion. And that's going to really test what anti-abortion legislators and prosecutors can do and really shift how the anti-abortion movement thinks about trying to control abortion in their states.
And I'm going to answer what we'd like to see happen in this area. So the virtual clinics that we've described, clinics like Abortion on Demand or Choice, they offer services that are less expensive than brick and mortar clinics, services that arrive in patients' homes between 2 to 5 days, and are afforded the privacy of taking these medications at home. And those are great benefits. But we'd like to see that those types of services and the telehealth mechanism for delivering abortion care, medication abortion, is part of a larger, incorporated and embedded in the larger national strategy to strengthen the telehealth infrastructure, to ensure that there's licensure compacts and waivers across states so that physicians can practice in their state and in others. And that the digital infrastructure, the problems of access are taken up by the administration, by agencies, by states, and that telehealth for abortion is not left behind.